All righty, we'll give folks a couple of minutes then to
Yeah.
use that QR code to
Yep.
apply for CME credit.
Yeah.
Just so you know, we're live streaming this on YouTube, and so we have a larger audience this morning than just UC San Diego. Technically, this is accessible all over the world. I'm just watching to see how many folks are logging in on YouTube, and we're getting a few, so
It's great.
a larger than usual audience for our grand rounds. Of course, the best part of this system is the cost. It's considerably cheaper than using a telemedicine bridge.
Yeah.
Well, our bandwidth's not quite the same.
So for the YouTube streaming, do they basically see your screen, or how's that?
They see exactly the same thing that we're seeing, and they just go on YouTube and it's there. It's on the, we have a YouTube channel for the Division of Trauma that was set up years ago, and that was started way back in about 2000 anyway. It's got about, there's about 800 videos on this channel. There's about 2 million views, and we have 10,000 subscribers. So it's a very popular social media outlet, and mostly it's trauma and burn videos, a bit of general surgery. But we try to record all of our lectures as well. So our Hansborough lectures for burn are there too.
Yeah.
And this one will be there as soon as we end the live stream, it'll become a permanent video.
Fantastic.
So Jay, if you don't mind, I'm just going to take a couple seconds to give everybody a heads up on the graduation activities. We put a lot of thought into this and had collaboration with the chief residents and the departmental leadership. We realized that nothing that we're going to do in a remote fashion is going to be anywhere near the celebration that the graduating chiefs deserve. But in this current time, we really can't see a way to get all the families together and to get all of us in one room. And so to that end, we're going to do a modified celebration that includes many of the components that we have in our graduation, but we promise not to do 4.5 hours of Zoom for graduation. We realize that would probably finish everyone off. So we're going to do a remote graduation with some catered food that will go to each of the chiefs' residencies, and they can have people over that they've been exposed to or quarantining with, and then we'll try to go through with our typical ceremonies, but in an abbreviated fashion. We've had input from the chiefs about what they think is really important in those components, and that's what we're going to do. So as far as the date, it's going to be on the same day that we plan to have the graduation. We'll send out an agenda and the specifics here in the next coming days, but that's the plan. And we feel really bad that we can't have the formal ceremony they deserve, but I do think it's important that we reflect upon their achievements.
Absolutely. Thank you, Garth.
All right, well, I think I'll go ahead with the introduction while folks get their last chance to use that QR code. So today's speaker is Dr. David Spain, and one of the pleasures of being a division chief is that you get to listen to your faculty tell you who they want to have speak. And so it was unanimous amongst our faculty that Dr. Spain would be this year's visiting lecturer for the Department and Division of Trauma. Dr. Spain is the chief of acute care surgery at Stanford University. He's also the general surgery residency director, and he's also the trauma medical director for Stanford Medical Care. So here's a true triple threat. He's a consummate surgeon, an esteemed and astounding teacher who's been very innovative with a lot of interesting programs, and also a researcher. And Dr. Spain is actually a Spartan. He undergraduate went to Michigan State, He did his medical school at Wayne State University in Detroit. Maybe that's where the trauma bug hit him. He did residency at Robert Wood Johnson and the University of Medicine and Dentistry of New Jersey. His residency was also at UMDNJ, Robert Wood, and then he did his fellowship in trauma critical care at Louisville. He has been a member of all the significant trauma societies. He's currently the president of the AAST. He's also been president of the World Trauma Coalition, and also sits on the American Board of Surgery as a council member. He's also the chair of the Critical Care Committee. He's also chair of several other committees of organizations such as the ATS, American Surgical Association, and others. He has 249 publications which cover a lot of clinical trauma care, but also a lot of work in disparities. He has got a ongoing R01 grant in disparities of care, access to care, and mental health issues after trauma. Those 249 publications have a Scopus H index of 49, which is probably the highest one I've ever seen for a trauma surgeon. So I think you're going to find that he is well qualified to talk about today's topic. And I would like to present to you, and looking forward very much to hearing from Dr. David Spain. Go ahead, Dr. Spain.
Great. Thank you, Jay. It's a great honor to get to be able to give this talk. But it's a great disappointment that I actually can't be there. The best part about being a visiting professor is meeting the residents and trainees and getting to spend time with them. So I apologize for the situation and not being able to join you, but hopefully we'll have a little bit of time together to at least hear my thoughts about acute care surgery, so how I think we got there and what's next. Excuse me a second. I have no disclosures, except that this is a very personal point of view. And so I feel a little bit like, Bilbo Baggins, it's sort of there and back again. So this will be my journey through this ordeal. I also used to be really worried, when I was much younger, that soon there would be no one to answer the call. And we were reaching a point where I was really concerned that we'd have a hard time attracting surgeons to come into the field and follow us. And was really worried was I part of the last generation? Was I, a lumbering dinosaur in the time of furry mammals? And so I'm going to spend a few minutes talking about some of the challenges of trauma surgery and how I think we got where we were and what we did about it, and then my thoughts about what the future might look like. So, there was a dramatic change in trauma care over the last 30 years or so. And a lot of it had to do with the epidemiology of trauma, the advent of non-operative and endovascular management, and some of the effects of injury prevention, to be honest. And this has significantly affected the practice of trauma surgery. And we were slow to respond. And I think it's also, academic and professional societies 30 years ago were very different than they are today. And there really wasn't an organized response to some of these changes, or even an acknowledgement that they were going on. So in many, in the 80s, many urban trauma centers were basically overrun with penetrating trauma. There was little time for anything else, really. And so a lot of trauma surgeons dropped elective and emergency general surgery because they had to concentrate on just getting through all the trauma volume. And for some of those surgeons, maybe just a little bit older than me, laparoscopy just went right by them. They didn't get it in their residency training, and there wasn't time or opportunity to gain those skills while in practice. And so, some of the trauma surgeons a few years older than me just never really learned how to do laparoscopy. So, the warning bell was really really rung by this paper by David Richardson and Frank Miller. And David Richardson up here in the upper right-hand corner, just clearly one of the most brilliant human beings I've ever met in my entire life. There's a reason he's been president of the Western Surgical, the AAST, the American Board of Surgery, and the American College of Surgeons, just to name a few. He understands human beings and groups of human beings and what motivates them better than anybody I've ever met in my entire life. It's incredible, his foresight, and then also Frank Miller. Frank passed away about 2 years ago, but Frank was the surgeon's surgeon. If you were a surgeon in Louisville and you needed a general surgery operation, Frank was the person you went to see. And they asked this question: will future surgeons be interested in trauma care? And they sent out a survey. Now, they sent a questionnaire out to about 1,800 general surgery residents, and about half of them replied. Now, for the residents, this is going to be hard for you to imagine, but this was not done on SurveyMonkey, or there wasn't even the internet then. This was done with paper, envelopes, and stamps. They mailed out 1,800 letters to residents, like a 4-page survey that you had to take a pen out and actually answer the survey and then put it back in an envelope and send it back to them. And it's incredible that they got a 50% response rate. Now, also surveys are kind of a new thing then, so there wasn't all the survey fatigue that's going on right now. But 66% of residents said that trauma care was rewarding. They thought it was a important aspect of their training, and it was a important thing they were doing for patients. But only 18% of them, 18% wanted it as a career or any sort of significant part of their practice. And then the question was why, And a lot of them, common reasons were sort of the increasing non-operative care of blunt trauma patients. So there was this, I don't want to, babysit patients for the orthopods, was, a common theme. And this was a time, right, when the transition was really coming from predominantly operative management to non-operative management. Some unsavory patients you meet who have suffered penetrating trauma. There were some concerns and some issues about lifestyle raised, but those really weren't as important. But the ones that really hurt was there's a lot of complaints about the structure of the current trauma rotations at a lot of institutions. And there was a negative impact of many trauma surgeons as role models on the trainees. So these last two really hit home. Those kind of really hurt a lot. But I think it's also important to know this was published in 92, so the survey was sent out in like 90, 91. Trauma centers and verification system wasn't that old back then. And a lot of these trauma centers, even when I trained at, so when I was a resident when this paper, I was a chief resident when this paper came out. And even at our place, we had 2 or 3, like 3 trauma surgeons. And then, all the other general surgeons took call. The surgical oncologists and the endocrine surgeons and even the breast surgeons took call as well. And, none of them really loved it and wasn't their career goal. And, they did not enjoy being on trauma call. And it was reflected in how they handled the rotations and the work. And that was a common scenario at a lot of places. So I think that, that idea that, well, you'll do trauma call for a few years until you build up your elective practice, and then we'll let you out of trauma call, and then you'll put the next, junior people in there. And that was a common thing. And that really negatively impacted the impression a lot of residents had on trauma care. It also, as I said, the changing practice and demographics of patients had a huge impact. So, we looked at the impact of the movement from non-invasive evaluation and non-operative management. And this was one of the more interesting studies I think we did. It was a 5-year period. We went from 580 DPLs in 1 year to 21 5 years later. It basically went away. And got completely replaced by CT scans and surgeon performed ultrasonography. And You know, the interesting thing was, if you look here, we did 580 DPLs. I went through most of those charts, and I can tell you fully a third of those patients had no indication for a DPL. He got an invasive procedure with, no hypotension, no abdominal pain, no tenderness, no physical findings. It was just purely based on paranoia and overaggression. But it also led to a lot of negative laparotomy. So about 15% of these DPLs were positive and led to a laparotomy, but fully a third of those laparotomies were non-therapeutic. So it was clearly overly sensitive, and a lot of patients got an invasive procedure for, really no benefit. And then 5 years later, we've dramatically decreased the number we did. A third of them were positive, and again, 6 out of those 7 wound up being a therapeutic laparotomy. But, the impact of all this in the residents was not insignificant. The number of operative liver, spleen injuries, went down over the same time period as we began doing more and more CT scan-based non-operative management. Others noted the same thing, that, the number of exploratory laparotomies, spleen injuries, and liver injuries managed operatively goes down as you use CT scan more and more. So you had this big decrease in the incidence of penetrating injuries during the prosperous 90s. A lot of trauma centers saw 35% reduction in penetrating trauma. The decreased use of DPL fast and more fast and CT scans led to fewer procedures for the residents, but clearly better outcomes for the patients. And again, this increased non-operative management of liver and spleen injuries. So, as I said, David Richardson was really a genius. I remember when I was a fellow, he was the program chair for the AAST, and he called me into his office in April, and he'd go, "Okay, come on, we're going to put the AAST program together." And he'd sit there and he'd pull out all the abstracts, and he'd say, we'll put this abstract on, and then we'll have Jay Doucette discuss it, and then we'll file it with this other abstract, and we'll have so-and-so discuss it, and they won't agree with each other, and there'll be this big discussion, and so-and-so will get up because they'll be mad, and he'd sit there and say all this stuff, and then just 5 months later, you would go to the meeting, and everything he said would happen actually happened. It was insane. And so when I was a junior faculty, he sat me down and he said, he goes, "You need to write this paper." And he wrote the title down, handed it to me, and of course I just said, "Yes, sir." And he said, the question was, should trauma surgeons do general surgery? And so we presented it at the AAST meeting in '99 when he was the president. And we just kind of asked the simple question. And at that time, we actually did another survey of the membership of the AAST. And at that time, the membership was a little bit different. It was a closed organization at that time with a defined membership number. So you had to be a little bit older and more established than right now. And so these are all people that have been out, at least 7 to 10 years. And 25% of the surgeons did less than 50 trauma cases and less than 50 general surgery cases in a year. So less than 100 operative cases in a year by a quarter of the membership. Now, some of this was due to, like, say, the epidemiology of trauma, but a lot of these people had pigeonholed themselves and weren't doing any general surgery, and many of them just didn't have the skill set, as I said. And so we looked at sort of our practice in Louisville, and I don't think this was unique, but we did all. It was a county hospital, and we were the trauma center, and we did all the general surgery there. So if you look at our volume over the course of a year, anywhere from a quarter to a third of our volume in that time was general surgery cases. And as I said, DPL going away, operative management decreasing. But when we looked at our elective or our surgical experience, our operative volumes for sort of the 5 core trauma surgeons, we were able to maintain our operative volume by doing a fair amount of elective surgery. This is me in the middle. And this is a 2-year period. I did about 250, urgent cases for trauma, and I did about 400 elective cases. So, 650 cases over 2 years, a little over 300 a year. That's, 6 a week. That's not a bad clip for being in the OR, for the residents seeing you in the OR. And then we thought this kind of got against this connotation that a lot of trauma surgeons were, doing non-operative management only and sitting in the ICU and, and turning knobs. And during this same time period, the five of us authored about 48 papers. 26 of them were trauma papers, but 11 of them were general surgery manuscripts. 11 were basic science, and we had 3 research grants, at the time. So, this is actually one of my favorite sentences I've ever, written. And it said, should trauma surgeons do general surgery is a philosophical question as much as anything, and therefore difficult to prove statistically. And really all we were doing was describing a model at our place that had worked. And we thought this general surgery model of trauma care maintained our operative experience and avoided a lot of that subtle second-class citizen connotations of non-operative trauma surgeons. And it was a description of a successful model at one institution, but a lot of places were using this model. UC San Diego, Parkland, and UCSF. I mean, there were a lot of places that were using this general surgery model, but it wasn't anything we sort of talked about or really acknowledged. And so the opportunity really was to embrace this. And the discussion was really, the paper was interesting. Brent Eastman got up and said, I think that trauma and general surgery model, it's a two-way street. Our experience with ATLS and damage control and critical care expertise will enhance the care of general surgery patients. Jerry Strach, same thing. You should be a broadly trained, practicing general surgeon with a genuine interest in trauma care. And this one is interesting because I personally have always described myself as a general surgeon with an academic interest in trauma care. And then Cross also noted the same thing, that this you can learn from both sides of the fence. So this was, I think, really a wake-up call at the time. And again, this was all driven by David Richardson telling me, that you had to do this, and he was clearly right. We can't change the nature of our patients or what's best for them. And but a lot of this was our own fault. As I said, there was poor organization and a lot of trauma centers and poor teaching on trauma rotations. And there was a lot of poor role models out there. And there were some lifestyle issues. We do a fair amount of night surgery, but that comes with the territory. But we never really defined trauma as a skill set. And as I said, anyone, in a lot of places, the model was, that anyone could take trauma call, and it was just something you did until your elective surgery practice took off. So, shortly after that, on kind of short notice, they set up a panel session at the college in 2001, and to discuss this whole topic. And there was Dr. McCursey was the moderator, and then Dr. Mayer, Dr. Hoyt, Dr. Meredith, and then myself. And I was like, I felt like the kid who spent their entire life sitting at the card table on Thanksgiving dinner, finally getting to sit with the adults. I was like, 41 years old, and here I am sitting up there with, sort of these legends of trauma surgery. And we had a pretty robust discussion about the future of trauma care. And it's one of those things at the college, you're never quite sure like how popular it's going to be. And the room was packed with people, and the discussion was very, very lively and very animated, and what really was the future for us. And then that following year at the WST meeting in 2001, obviously didn't happen that year. And so Ron Mayer was extended for a second year and gave his presidential address in 2002. And he really talked about this idea about how we are sort of undervaluing who we are and what we do, and how the model of trauma care and trauma systems and the efforts that we do in performance improvement and quality assurance really could be a paradigm for medical care in the 21st century. And then the following year, David Hoyt, followed this up and again talked about staying focused and on our way to greatness. And he really specifically said that we are at a crossroads, and we were having a debate about the future of our profession, whether we were going to adapt and flourish or whether we were going to die out. And some of this was driven by the over-specialization of general surgery, the decrease in operative trauma care, and competition from emergency medicine and other groups that were, expressing interest about possibly taking care of some of these people. and people took a lot of bad jobs at that time, especially less. I think maybe less so on the East Coast or on the West Coast, but on the East Coast, there was a lot of people taking bad jobs at this time, where they were really only allowed to do trauma care and nothing else, and not even necessarily critical care, and they were basically forbidden from having like any general surgery activity. And so as David pointed out, first and foremost, you got to have a clear vision, because without that, you're just in a state of confusion. And that's where we were. We were really in a state of confusion because we just didn't know what we wanted and what we needed to do to move forward. So he put together this group of surgeons and sort of charged us to come up with what's the future of trauma surgery, and how do we make this better. And so first thing we just had to better define what we meant by a trauma surgeon. And one of the key things we had to do is enhance the operative experience of trauma surgeons, but also the residents in training. If we didn't improve their operative experience, then we were going to have a hard time convincing them that this was the field that they should pursue for their career. So, we had to find a way to get surgeons into the OR and doing cases and valuing that aspect of our care. So we talked about a lot of different models. There was a little brief discussion about the comprehensive model, and maybe we could do basic orthopedics and in basic neurosurgery. When I was a resident, we did not have a neurosurgery residency program. So when I was a chief resident and interested in trauma care, I scrubbed on every single craniotomy that was done. I still think I could probably take a bone flap off and drain a subdural, but it's the idea that we would actually do that in practice is that quickly died out because there was just too many problems with that. And when we talked a little about the European model, where they do things a little bit differently and do some of the rudimentary orthopedics there too, and that quickly died out too. And there was a pretty robust discussion about, should we just let it die? I mean, really, are we just lumbering dinosaurs? And maybe we just let emergency medicine, evaluate and resuscitate the patients and let some intensivists take care of them. And then, you can call us if they need a abdominal operation. Otherwise, we'll let somebody else do all the non-operative care. But, maybe you could dress it up, but it just still wasn't going to be very attractive. And maybe that's what we needed to do. But, honestly, who else, except for us and our emergency medicine colleagues, are really going to take care of these patients and resuscitate them? And who else is going to take care of this patient, right? This lady, all 4 limbs are broken. Her bilateral femurs are in traction. She's got bilateral chest tubes in for severe pulmonary injuries, and she's got a double lumen tube in with independent lung ventilation for her bronchopleural fistula on the left side. I mean, really, who else would take care of this patient like we can? And so we really didn't think we could abandon patients. We really had to maintain our commitment. But we had to develop a specialty that would offer an attractive, viable, and sustainable career and lifestyle. And it had to be recognized by the public and the profession as valuable. And we just went round and round and round with these discussions. And then finally, it was Frank Lewis, who was another amazing thinker and brilliant human being. And Frank, finally said, what is the what's the unmet need of patients, right? Serve the needs of the patient and all your problems will go away. And what was the unmet need of the patients at that time? It really was emergency general surgery. There are all these articles coming out. There was an article published from the California American College of Surgeons chapter where they looked at specialist availability for emergency room call in California. And fully, a third of the ERs had significant problems with on-call surgeons, including general surgeons and some of the specialties. And so when you looked at it, this was the big unmet need, was emergency general surgery. So again, who better to do it? A lot of people are shying away and getting out of ER call. They're already our best referral source for trauma case patients. And this was, somewhat of a pragmatic decision. And so again, the problem's not the problem, it's your attitude about the problem. So we decided that we needed to embrace emergency general surgery. And that was the big decision. And that, in a lot of places like us and in UC San Diego, like we had always done the emergency general surgery at our place. We just didn't really talk about it, and we didn't really focus on it as a part of our identity in our practice. But this fits in well, we're already on call. The ER deals with us a lot, and sometimes they actually even like us. A lot of these emergency general surgery patients, they're elderly and quite ill, and we are accustomed to operating on critically ill patients with incomplete data. This is, kind of what we do. So it had a lot of advantages. There were fewer problems with turf, having to retrain people. It was, probably the quickest solution to enact. And there were already some models out there, that this could work and attract fellows and, maybe could lead to some elective surgery. The disadvantage is another patient population where you're sort of just dependent on whatever comes in through the door. And it could mean more nighttime operating. But we thought there's a growing need for this, and that the competition for call wasn't going to get more. It was going to get less, and that there was going to be a burden. So really, the discussion became about how to address the unmet need in this. And then eventually this has led to the whole concept of acute care surgery. We went back and forth on different names and different models. And this was the one that finally kind of hit home with everybody, that we would adopt this idea of acute care surgery. And the AAST immediately came up with a curriculum and a training paradigm for fellowships. And, and over the years, we've had a fair number. I think we're up to almost 30 acute care surgery fellowships now, and we'll probably go over 30 this year. People started writing about this whole idea, how do we train people? What's the practice models? And, so it became a big area of interest. And then, more importantly, people actually realized like this whole general surgery population was a group that hadn't been well studied. So people started looking at different risk models and how do we risk adjust the emergency general surgery. The UCSD group, what's the sort of the health policy issues, and what happens to uninsured patients during the Affordable Care Act who have general surgery problems. So people realize that this whole patient population was a interesting area for investigation and even policy work to improve access and care for these patients. But, as Deming said, without data, you're just another person with an opinion. So, so what does the data show? I mean, is this really, having an effect? Well, when we sort of started on this journey, the number of people doing surgical critical care fellowships was about 50 nationally. Now, I still think if you want to do surgical or acute care surgery as your career, you need to be a well-trained general surgeon. But the ticket you need to sort of get into the dance now is still the surgical critical care fellowship. I think if you're a well-trained general surgeon and have trained at a great program and you have this certificate, then that's mostly what people require right now. In terms of hiring acute care surgeons for either private practice at level 2s or even faculty at most university programs. So we had about 50 people going into acute care surgery in 2005, and we were only filling about 50% of the fellowships. So about 100 fellowships then. 2018, we got over 200 with over 80% of programs filling. Excuse me. And then in 2019, we're up to about 143 programs with about 260 slots. 82% of them filled, and we matched 237 fellows. So it went from 50 to 237. Now that doesn't sound like a huge number, but when you think about it, that's 1 out of every 6 chief residents is going into surgical critical care right now. And we are the biggest fellowship or board certified fellowship in general surgery by far. And I think not only as quantity, but also the quality of fellows applying to our program is every year it's better and better. And I think, if you go to the AAST meeting, there's a lot of enthusiasm. I mean, there's a sort of a palpable excitement at that meeting that, wasn't there 10 years ago. And as evidenced by the fact that last year the AAST started this associate member category for fellows and residents. And I was going to be happy if we had like 30 or 40 people join the first year. We had 110 people join the first year. So I do think there is genuine excitement and interest in this. But, we had these arguments back and forth about why. Like, what is it that, why is it that now, 1/6 of all general surgery residents are going into trauma in critical care, and what's the driver? And I had my theories, and my pre-test assumption for this was that a predictable schedule and team-based care were going to be the most important reasons that residents were going into trauma and acute care surgery. And those were important, but not close to being the most important thing. Really, the most important things were developing a broad skill set, taking care, doing complex problem solving, and caring for the sickest patients. And this is what's really driving the interest in surgical critical care and acute care surgery. And it was again not what I would have predicted as the top three, but it was fascinating and pretty consistent results. So broad-based, complex problems, sick patients. That's what's interesting and drawing residents into this field. And then, you look at, the academic output, 2003, this wasn't a term that anybody utilized or recognized. And in 2019, in PubMed, you got a little over 500 or almost 500 publications if you put PubMed or acute care surgery in PubMed. So again, I think people have realized this is an area where a lot of opportunities for scholars. But that's all good. But what does it mean for patient care? These are probably the two best papers, and I say best in quotes. This is a systematic review of basically all the papers that have been written about having a dedicated emergency surgery service. And there are about 27 studies, and basically showed that, when you aggregate them, that morbidity and mortality were improved, and that finances were actually improved, and they were a little bit more cost effective if you had a team dedicated to taking care of those patients and moving them through the system. And again, assuming you had the right resources, so centralized unit, access to OR, radiology, ICU beds were all things that seemed to help this model. Now, if you look at this paper, almost 80-90% of the papers in there are really about a specific disease entity, cholecystitis or appendicitis, and and that's what the vast majority of papers are about. So I'm not so sure that that's going to give you wide-ranging support that's good for all of general surgery. But this paper out of Michigan, where they have a very interesting process there. They have this Michigan Quality Collaborative that is basically a statewide consortium of all sorts of different hospitals, community hospitals, academic centers, hybrid places, teaching hospitals that participate in this. And it's a unique thing that they have in Michigan, and supported actually by Blue Cross and Blue Shield, because they're the predominant healthcare provider in the state, and they figured it was worth their investment to support this effort. So they have this big statewide collaborative, and they got 34 of their hospitals there that participated in this one, looking at the patient care model for emergency general surgery, and comparing those that had who's ever on general surgery call set up versus those that had a dedicated emergency general surgery service. And they looked at all laparotomies for anybody over 18 who underwent a laparotomy exclusive of vascular or OBGYN procedures. And their overall mortality was about 4% for emergency abdominal surgery. But it was highest in patients who required a bowel resection. So it was about 11% for for those who required bowel resection. And when you broke it down, whether you were at a general surgeon on call model versus an acute care surgery model, mortality was about 12 versus 8.5%. So about a 31% reduction in mortality for those people that were cared for at a hospital that had a sort of a system in place to deal with general surgery emergencies. So again, not necessarily, this is a well-established collaborative that sort of collects research quality data. But this was just a minority of the hospitals that are in that whole system participated in the study. So I think there is some data out there that this model may improve care, mostly by organizing the resources into a system of care. So what do I think is next? I think that the job market and trauma in acute care surgery is pretty strong. I think that so far our fellows and people I've talked to over the last several years have not had a hard time finding good jobs. I think both in academics and in community setting with a lot of level 2 trauma centers. Again, the number of acute care surgery fellowships is steadily increasing. I think there's 150 or so surgical critical care fellowships. About 30 of them have pursued this the second year acute care surgery fellowship. I don't think that number is going to grow a ton unless and until there's formal recognition by the Board of Surgery. I think if there's ever a focused practice designation or a board certificate in acute care surgery, I think that's when you'll see the number of fellowships take off. Because then I think, if there is a certificate associated with it, that's something that will drive the interest. We have yet to pursue this because I'm having a hard time trying to figure out how I would organize this without impacting my residents too much. I'm trying to get our county hospital to pitch into this, and I think if we can do that, then that's a real possibility there. But I do think I think there's an actual opportunity that the board might be interested in doing something in terms of formal recognition. And if that happens, then that's when I think that the number of these surgical critical care fellowships that add on a formal second year will probably take off once that happens. But as I said, I think we're going to go over 30 this year with about 50 plus fellows, which is a reasonable number. One area where I do think we've dropped the ball on is elective surgery. I think total reliance on whatever comes into the ER as a trauma or an emergency general surgery, leaves you vulnerable. And I think having some elective surgery practice is a good thing. I also think it makes you a little bit jaded and affects your perspective a little bit if you don't do some elective surgeries. So, I always talk about the minister. So I had this, old Baptist minister I took care of for a long time. I think I operated on him 4 or 5 times over 10 years. I, treated his necrotic pancreatitis, and then I, did a bowel obstruction on him, and then he developed a ventral hernia, and I fixed that, and then he developed a diverticulitis and a colovesical fistula, and I fixed that on him. And I got to know him and his wife very well, and he come in to see me for post-op visits and bring me vegetables from his garden. And every time I operate on him, he'd make me come to the pre-op area, and he'd make me hold hands and pray with him before we go into the OR. And really got to know him. And I think you have to have some patients like that, because if all you're operating on are patients you've never really met before, I think it just throws you off a little bit. So what can you do? I think there's some practices that are possibilities out there. Abdominal wall reconstruction. I think it fits in nicely with the trauma and acute care surgery model. As you guys have noted, we do a lot of this, right? We spend a lot of time taking the abdominal walls apart and putting them back together acutely. I think we're well qualified to do those electively as well. And like I said, if you just give a talk at your local, ACS chapter meeting and tell the surgeons in practice that you like doing abdominal wall hernias, they'll send them to your clinic pretty quickly. There's some other things, procedure teams, the hospital, it's not glamorous, but it's stuff that needs to be done and can expedite care. Chest wall reconstructions, we've started getting into this a little bit recently. I was a little bit of a little bit slow on this. I think some of the products have improved. I'm still really waiting for dissolvable plates because I think that's the actual long-term answer. But we're doing more of these acutely, and now we're actually starting a outpatient clinic for delayed treatment of some of these patients. It turns out a fair number of these people actually down the line at 6 months still have non-union and chronic pain. And so we're actually opening up a outpatient chest wall reconstruction clinic. We've had a little bit of a soft launch recently and getting some interest. And then once all this pandemic effects slow down a little bit, we're going to have a real launch of our chest wall reconstruction clinic this fall. Again, and then necrotizing soft tissue infections. Again, this is another area that where you can actually add some value. And then I get most of the abdominal wall reconstruction cases at our place because I expressed an interest, and I get I also have over the years have built up some referrals from we have a big sort of connective tissue, Ehlers Danlos, Marfan group here. So the cardiologists send a lot of their general surgery issues to me. So there are some opportunities out there. So, I say that, the truth about acute care surgery, I think developing an elective component is the next big challenge that I think our profession and academic societies needed to take on. But, we've jumped in this whole hog, and we've rebranded ourselves. We are acute care surgery division, and that's, our identity now. And so we've sort of jumped in with both feet in this. And we are the faithful here. So again, I think the research opportunities are real. There's basic science, clinical trials, outcomes prevention opportunities out there. The UCSD group's been doing this for 40 years. Dr. Shackford, Dr. Hoyt, Dr. Coimbra, Dr. Doucette, the whole gamut from clinical care to research to leadership. Your group's been doing that, as well. And the patients can be very rewarding as well. Like all you need is like one patient like this every once in a while that sends you a picture. This lady, she did give me permission to use her image, but this is trauma patient that we helped put together, and a year later she has got her life back together and sends you a picture like this. It's fantastic. And I think the last thing is the lifestyle can be excellent. Yeah, we are on call. We're here in the hospital at night. We're up some nights, but if you have great partners and great teamwork, this is really what you need to emphasize. So, if you got a strong team who works together, then, basically every day can be the best day ever. So I'd like to thank Jay and the whole UCSD team for asking me to do this. I wish I could be down there to spend time with the residents, but we'll figure out a way to get together again. I'd be happy to answer any questions. Thank you.
Well, thanks very much, Dr. Spain. That was a fantastic talk, and we do appreciate it very much. I guess we should open up to questions. We have a little bit of time to have questions. I'll check on the YouTube and see whether or not any of our YouTube viewers have questions as well. But what questions do we have out there? While our folks are writing them up, one thing I'll ask you is, since you're now the general surgery program director, is if I'm an intern or junior resident and I'm still not quite decided about a career in acute care surgery, what can you say that would help me make a decision?
Yeah, I think one of the best things is, the problem if you're a junior resident, you only know what you see, right? So you've only seen one model or two models, maybe what you saw in medical school and where you're trained at. So I think, the thing that hooked me, I went to the AAST meeting as a PGY2, put together an abstract, went to the meeting. And when I saw the people there and the way they interacted and the way they worked, I just drank the Kool-Aid. I mean, so I was hooked. So, if you can get to the AAST meeting or, even a regional meeting, to me, that's, the best thing to really see what does it look like? Because again, you're as a resident and what your career is like as an attending are really two different things.
David, this is Brian Clary. Again, thanks so much for joining us virtually. It's been an extraordinary talk. It's kind of interesting. I really appreciate you bringing us through really from the ground up, the building ultimately of the specialty. And it's interesting as you look at it, ultimately the answer was specialization that focused on a specific group of patients who ultimately had an unmet need. And it's not just about the technical aspects of how you do a lap chole or an appy or a diversion of the bowel, but it's more about the processes of care, et cetera. So it's interesting to have seen this. The answer for the trauma group was specialization. And perhaps they were swimming against the tide for a long time with respect to specialization that everybody else was ultimately doing in surgical oncology, et cetera. And they were maybe resisting the notion that this was a specialty and needed to be developed. And so I want your kind of opinion on that. My second question is, if you look at, for example, the Michigan Collaborative, the morbidity rates are the same.
Yes.
So ultimately, it's about failure to rescue and the ability to bring people back from complications. And I would surmise that in many of those institutions in Michigan that had an acute care surgery model, they were largely probably larger institutions, academic institutions that had residents, which are associated with better failure to rescue, and also specialists as well. And so I'd be interested in your thoughts on maybe the reason as to why you saw improvements in mortality in that experience. But again, thanks so much.
Yeah, Brian, that's fascinating because, in 20 years of this, I've never heard anybody do that analysis that we solve the problem by specializing. And I must admit, I've never thought about it in that way or heard anybody else say that. But that's a fascinating observation. But I think it's correct, right? We specialized in taking care of critically ill, sick patients and in trying to meet their needs. So I'm going to steal that idea, but I think you hit the nail on the head. Those are a group of patients that need, and again to your second point, which I think they sort of do go hand in hand. It's not the technical skills, it's not the, that I can do a lap chole better than somebody else. That's not it at all. It is the system of care, in that which leads to the ability to rescue, as you said, and that's how trauma care has been built, and we've just taken that same idea and sort of applied it to this other group of critically ill patients who have general surgery problems. And Andy Peitzman at University of Pittsburgh has argued that the sort of three pillars of acute care surgery are general surgery, trauma, and critical care, and he's argued that the fourth one should be rescue. Surgical rescue. And then also, and then add to that, Ron Maris suggested that the fifth pillar might actually be palliative care, and that, due to the fact that we're taking care of so many critically ill patients, both injured and critically ill, that'd be another thing. But I do think that it's the system of care. It's not the surgeons. It's the group of, we're not trying to run the clinic and do our elective cases and take care of an emergency general surgery problem. We're hospital-based physicians that, are there to take care of critically ill patients. It really is the system and the ability to rescue because of those, people that we have in place.
Dr. Spain, I have a question from Dr. Leppert, who's one of our trauma faculty. Go ahead, Amy.
Good morning, Dr. Spain. Great pleasure to see your talk this morning. I very much enjoyed it. The history of it. I had the opportunity to first meet you. I think it was in around 2003 at a AAST meeting and have gotten to know a lot of the folks that you mentioned in your talk. I remember the discussions about what the future of acute care surgery would look like, and now find myself as the medical director for our emergency general surgery service here at UCSD, having just recently joined the faculty here. My question for you is, understanding the history and being where we are, what do you see as acute care surgery and emergency general surgery 2.0? How do we get that data? How do we build the next level of IT development to get the information we need to take this to the next level?
Yeah, great question. Well, first of all, welcome to California.
The weather's much nicer here.
Yeah, you tell you you'll spend a nice winter time here compared to Madison. You'll be happy. Yeah, I think this is one of the things where we've been having a debate recently. One of the things that has helped trauma care is our registry. We have a detailed registry with tons of data that we can really use for quality improvement. And actually, if you go back and look, that really was a lot of it driven by David Hoyt pushing that agenda, 30 plus years ago. People bought into it. I don't see any way we're going to be able to do that for general surgery. A comprehensive registry like we have for trauma, for emergency general surgery, I think is cost prohibitive, where you put every patient in there. I think the alternative would be to use the emergency general surgery module of NSQIP. The disadvantage of using NSQIP is it's a sampling methodology and it doesn't capture 100% of your data. So for research purposes, it may be not as great, but for quality improvement stuff, I think it's probably a more economical answer. So I do think the next version is what's the data going to be? I think that we're probably going to settle on a NSQIP EGS model. There's some talk about verifying emergency general surgery centers like we do trauma centers. I'm not sure that's going to fly. I'm not sure what the motivation for our hospital would be to pay extra money to be verified as a emergency general surgery hospital. I don't think that's going to make more ambulances pull up to the back door, but we'll see. I do think the research opportunities are significant and still exist. So.
I'm looking on YouTube, and we managed to hit 12 viewers on YouTube, which is pretty good given our first time out, but they're pretty silent. They don't want to ask any questions. I guess we do have time for maybe one more question and before we're out of time. If not, I'll hand it back to Dr. Clary.
Thanks again, Jay, and thank you again, David, for joining us. It's been an extraordinary talk and very thought-provoking. Actually, my last question to you, David, is how do we get Stanford medical students to come to UC San Diego for general surgery residency? Maybe you and I can have an offline conversation about that.
Yeah. It's interesting. We have a relatively small pool. Stanford's a pretty small medical school, and 90 students. So every year we got about 4 or 5 that want to go into general surgery, and almost one of them is always from the East Coast and want to go back, which I don't understand. But we'll see. Yeah, we should collaborate on that one.
Absolutely. Thanks again, David. Really appreciate it. And thank you, Jay.
Thanks a lot.
Thank you, everybody.
Thanks for a great talk, and we look forward to seeing you in San Diego soon when it's safe.
Yeah. All right. Thank you all.
Bye-bye.